Hello, and welcome to the UCLA Neurosurgery Clinical Advances series. My name is Dr. Jeremiah Johnson. I'm a part of the neurosurgery faculty here at UCLA. Today we're going to talk about a little known but definitely growing disease process for us becoming more aware called superior semicircular canal dehiscence. Today we have two experts in the diagnosis and treatment of the disorder, Dr. Isaac Yang and Dr. Quinton Gopen. Thank you for being with us today.
Thanks, Dr. Johnson. Thank you for visiting with us here at UCLA, Ronald Reagan UCLA Medical Center. My name is Dr. Isaac Yang. I'm a professor of neurosurgery, head and neck surgery, and radiation oncology. And it's just a pleasure to be here, and I just want to thank you for being here. And I want to introduce my colleague, Dr. Quinton Gopen.
Thank you, Dr. Yang and Dr. Johnson, for your time. So my name is Quinton Gopen. I am one of the Department of Head and Neck Surgery neurotologists, and that is a doctor that specializes in ear and skull-based surgery. And I've been lucky enough to team up with Dr. Yang to provide the best possible care for patients with the diagnosis of semicircular canal dehiscence. Thank you.
And it's really a pleasure and an honor to be talking about superior semicircular canal dehiscence. And to give an update on the videos that we do on this disease, I think the last time we did this was maybe 4 or 5 years ago. And so it's really a pleasure to talk about this and see where the field has moved in that time. So semicircular canal dehiscence, as Dr. Johnson just said, is a mouthful. Sometimes we abbreviate this as just SSCD, and that's kind of an easier way for us to talk about it. Even though it's a mouthful and it sounds super complicated, in essence, the disease is very, very simple. What you have is a tiny hole that develops right here. And that tiny hole develops because you have a small opening in the inner ear structure, and that opening creates a gap. And then now the brain space can communicate with that tiny hole. What problems does that cause, Dr. Gopen?
So that's a great question. So usually patients are going to present with auditory, meaning hearing, or vestibular, meaning balance symptoms. And we have some upcoming slides to go through the various symptoms that they could be presenting with. There are also other symptoms like fatigue, headaches, those sorts of things, and we'll go through that as part of this discussion.
And as Dr. Johnson mentioned, this is a newer diagnosis, first described and defined in the late 90s, early 2000s. And that's really because at that time, that's when these CT scans, like you see here, became high resolution enough. Before that, the resolution of the CT scan wasn't good enough really to pick up on this disease. And so for the epidemiology, and that's just a complex word for how frequently does it happen and in which kind of population does it happen, this disease happens more commonly in older patients as they approach their fourth or fifth decade of life, so in their 40s or 50s. And there's also a gender predisposition. Dr. Gopen, can you tell us about whether this occurs more commonly in men or women?
Yeah, so in our series, and we have quite a few patients that we follow, as you can see, there's a female prevalence. It's not exclusively in women, but certainly we do see it more often in women than men, and most of our patients are in the 40s and 50s, but we've seen the diagnosis in small babies up to 80 and 90-year-old patients.
And that makes a lot of sense because SSCD really is just a thin bone disease. It's a bone disease more than anything else. And women have a higher incidence of bone and bone thinning like diseases. The cause of it is unknown, but it is associated with osteoporosis and head trauma. So what does that tiny hole cause? It's a tiny hole between the inner ear and the brain, but it can cause big problems. What are the auditory problems that it can cause, Dr. Gopen?
Yeah, the way I think about the condition is there's a normal seal of the inner ear, the organ of hearing, and when there's an abnormality in that hole that exists, sound energy can penetrate that shouldn't. And so you hear a lot of internal sounds being amplified. It can be your heartbeat, which is common, your own voice when you talk. Some people describe their eyes moving, blinking, digestive sounds, but it's an internal amplification of sounds that's a big hallmark of it. People will hear the run-of-the-mill tinnitus. They may have hearing loss from the condition, ear fullness. That's all part of the spectrum of the auditory dysfunction that people with SSCD will experience.
So patients can hear their own heartbeat, their own voice, and their eyeballs blinking?
Yeah, that's correct. So there aren't a lot of conditions that would do that. So I would say in general, if you're concerned about hearing abnormal sounds like your heartbeat along with your voice like an echo and you can hear other internal sounds, there aren't a lot of other diagnoses that would explain that, and this would be probably the leading possibility.
Things that come to mind are like patulous eustachian tube or glomus jugulare tumor. But really, yeah, I think if you hear your heartbeat, superior canal dehiscence has to be on the differential. What about balance symptoms? Can you get balance symptoms with SSCD, or is that not possible?
Sure, it is again an abnormal opening into the balance chambers, and so as such it causes balance dysfunction. Some people have attacks where the room spins around, other people will feel more like their balance is off, and they'll have episodes of what we call disequilibrium and everything in between. So it's very variable, but a lot of patients will present with some degree of balance dysfunction or dizziness spells as part of the condition, and sometimes that's with pressure or sound inducement. So if particularly you're doing something that's either loud or pressure that causes the dizziness, that's again concerning for this diagnosis.
So pressure and sound can cause dizziness as well too?
Yes, I would say that's certainly more concerning for this differential diagnosis, would be pressure-induced symptoms.
And that makes a lot of sense to me, because if you look up the superior semicircular canal, just Google it or go to med school and look at what it is, the superior semicircular canal is actually a balance organ. It's not designed, it wasn't made to hear, it was made to keep your balance functional. So it makes sense that a hole in that organ would cause you to have dizziness.
Yep, I agree.
The other question we get commonly though is, can you have SSCD and only have balance problems and have none of those hearing problems? Let's say I have SSCD, can I have presentation with just balance problems and I don't hear my heartbeat, I don't hear my voice, but I just have dizziness? Is that possible?
So it is possible, and certainly we've seen patients. I would say it's not the majority of people, but certainly you can have either exclusive auditory symptoms, meaning you have no balance and dizziness at all and you just hear internal sounds amplified, or other auditory symptoms, or vice versa, where you just have vestibular symptoms only. Obviously, the more specific you have symptoms like pressure or sound inducement, the more we're concerned about this diagnosis. If your only symptom was you have some dizziness, well, there's plenty of other conditions that would explain that, and we would actually have to use other testing to figure out what is your cause of dizziness.
So there's three really kinds. You're saying you can have auditory symptoms and hear your heartbeat and your voice. You can have a different kind, which is just principally balance. And you can have a third kind, which is you have both symptoms of both sound and balance. But SSCD can cause all those kinds.
Yes, but the most common presentation would be a combination of both the auditory and the vestibular dysfunction, yes.
Sure.
I wanted to jump in just for 1 second. Just in the event, I know you're about to cover it, just to step back and say, like, how is the hearing system designed, right? So for those that haven't been to medical school, there's a series of organs based in the skull on each side. It's completely surrounded by bone for the most part, with the exception of the portions that transmit the sounds through our eardrum. And then there's a nerve that leaves those structures and goes to the brain. And that's how both the balance and the hearing are interpreted, or sensed and sent to the brain to tell you where you are in space and that you're hearing sounds. This particular disease, as I'm sure we'll show here in a second, is a dysfunction of that system, whereas some of the bony covering is eroded, right? And there's a connection to the brain and the fluid of the brain that throws off the system. And so that's where these symptoms come from. I just think it would be really nice to summarize all these things, and I'm sure you're going to get to it. So thanks for giving me a second to clarify.
Sure.
Yeah, I mean, that's exactly what Dr. Johnson said is correct. Your sound system has to be encased in bone, and there are two openings. One, and I don't want to get crazy technical, but it's the oval window and the round window. Sound goes in the oval window and out the round window. And that's the way it occurs in the regularly designed cochlea. The problem here is that because there's another opening, a third opening, instead of two openings, there's a third window, a third opening, sound is now escaping out the superior canal dehiscence. And that's a problem. And we recently heard a really interesting talk where when you do a round window occlusion, which is one of the older ways to treat this, if you block the round window, you make SSCD worse. And the reason why is because instead of sound escaping out the round window, now you're forcing all the sound out the canal dehiscence. What do you think of that?
Well, it's, I would say, a little controversial. I think some people do have benefit from round window occlusion surgery. There are some, which we will review later in this discussion, some case reports of how people sometimes improve and how they don't, but it is variable, and there are certainly some patients that do get worse with the procedure, but it was an interesting talk, yes.
It was a really good, interesting talk. But like Dr. Johnson mentioned, how is this disease diagnosed? And I think the gold standard is going to have to be a CT scan, a high-resolution CT scan. And I think that's what changed in 1998 and the early 2000s on when the disease was given a name and when we started treating this, is that before that time, CT scans weren't high enough resolution. And now, at that time, they became higher resolution. And now CT scans are even better. What do you think about CT resolution, Dr. Gopen?
So certainly resolution has improved. I do feel that the diagnosis is important to include more than just a CAT scan finding. And so we do know from reviews and literature that just a CT scan showing dehiscence by itself is not, I would say, sufficient to give a conclusive diagnosis. So we're always looking for supportive information, as you know, and there are criteria that have been set out, including some of the other symptoms that are more specific for the condition, other objective findings on hearing test or VEMP testing, which we can certainly go through, but the CAT scan is a very important part of the diagnosis, and obviously that has improved as the resolution has gotten. We typically get scans that are 0.6 millimeter slices. And
0.6 millimeter? Less than a millimeter?
That's right, 0.6, that's the standard. If they get thicker than that, it gets too blurry and you can't tell with definitive identification of the dehiscence. And so that's the gold standard, is 0.6 or better, meaning thinner slices, continuous slices in the coronal view.
And that really speaks to one of the things that we do really well here at UCLA. We're a multidisciplinary team. Dr. Gopen is an ENT surgeon. Dr. Johnson and I are neurosurgeons. But the team that also supports our program here at UCLA, including neurocritical care, neuroanesthesia, and specifically here is neuroimaging. Dr. Noriko Solomon, Director of Neuroimaging and Neuroradiology, and that whole team here at UCLA, they give us fantastic imaging. What do you think about the resolution of our temporal bone CTs to diagnose SSCD here?
Yeah, they're excellent. I have great confidence. It's something that we always try and get if we can to see directly ourselves. Certainly other locations can give good quality scans, but we, I believe due to the volume and the number, they know exactly how to do the scans here. It's a very dialed in system, and I'm very confident when I look at our CAT scans here internally that they're going to be high quality.
Yeah, and that it doesn't just go to our surgical experience. It goes to the neuroradiology, the neuroimaging experience. They've seen thousands and thousands of SSCDs, and so the resolution of our imaging, they know what to look for, and so our imaging, I think, is phenomenal, and our neuroradiologists that pick this up, they're exceedingly good.
I agree.
So how do we treat SSCD, Dr. Gopen? What are the ways we can treat this?
Well, I would say in general, surgery is something that obviously is available. We try with medical management for most conditions, but this is a particularly difficult one to address with medical management. So there are no medical cures for the internal sounds that you hear. A lot of the symptoms that are bothering patients are not very well or at all addressed with medication. And so particularly things like dizziness and balance problems. Our mainstay of treatment for semicircular canal dehiscence is surgery, and for as much as some patients are hoping to avoid surgery, that is the workhorse that we use to treat this condition.
You know, that's something different now than it used to be 5 or 6 years ago, is that there's a explosion of sound canceling and sound canceling. 5, 6 years ago, it was the overhead big sound canceling. I think Bose made them back then. And so we saw a lot of our patients coming in with sound canceling. But now there's a lot of tiny earbuds that Apple makes, Samsung. We don't have any endorsement of any kind, but a lot of active noise canceling sound earbuds that help patients with either sound sensitivity or really for their balance induced by sound. What do you think about patients temporizing with sound canceling headphones?
Sure, it's avoidance. Obviously, they're just trying to avoid the provoking factors of loud sounds, and those are very effective ways of doing that. And I think we all try our best to modify our lifestyles to adjust to whatever medical issues we're dealing with, and that is certainly one way, but it's certainly not curative. You're not changing things in a way other than just avoiding them, which is a very powerful technique, but when we're talking about definitive treatment options, surgery is definitely the main option.
So I think there are 3 main treatments or surgical ways that you can go about repairing semicircular canal dehiscence. The first one is a round window procedure. Tell me more about round window procedures.
So we don't tend to do round window surgery very often. It is something that is highly variable. The outcomes are very unpredictable, I would say, and sometimes worsening. It is a very simplistic procedure. You go in through the whole of the ear, so there's no cuts externally. You move the eardrum out of the way and you go down to that exit point of the inner ear, the round window, and put a little tissue there. And so there have been some studies that show that improves some of the symptoms. There have been some studies, as you mentioned, that show that it doesn't do such a good job. There are small studies, and we really reserve it for patients that are too medically frail to undergo surgery, that are desperate and have very little other options. So we do not do it very frequently at UCLA.
The second approach that you can talk about is a transmastoid approach. I know you're going to be more familiar with the transmastoid approach than me. What do you think about the transmastoid approach to repairing SSCD?
So certainly as an ear doctor, I'm doing a lot of mastoid surgery. So going through the mastoid is a very comfortable approach, but it's not a great one for semicircular canal dehiscence.
So you do a lot of mastoids?
I do.
Like thousands and thousands, would you say tens of thousands or thousands and thousands?
I've lost count long ago.
Can you give us a quick overview of what is the mastoid and why you would go into it?
Sure. So the mastoid is a bone right here behind your ear. Just like you have air pockets in your face that are sinuses, you have an air pocket behind your ear, and that is called the mastoid. And you can access these balanced chambers by going through that air pocket behind the ear. It's an awkward approach for getting to the top of the balance canal where the dehiscence is. And so in semicircular canal dehiscence, the lesion, the opening is at the top of that balance chamber. And when you're coming through the mastoid, you can only get to the base of that canal. You cannot get on top of it and see down into it. So it is not an easy approach for getting good exposure. So what some individuals do is they open up the balance canal, not where the lesion is, in a separate spot, and try and plug it so that it no longer has functionality. But that's a very aggressive way to do the surgery. So by drilling open the canal, you're traumatizing it by then packing it off. I have seen a lot of complications and problems with that approach. And so at UCLA, it is certainly not our preference. There are select rare cases that we cannot approach from above, which we'll be going into shortly. And we do have to do a mastoid approach, but for the most part, we consider it to be a more aggressive and invasive technique that isn't warranted for the majority of our patients.
Yeah, and so at UCLA, we try to repair these through middle fossa craniotomy, which we'll talk about next. But there's been some scientific literature that suggests that the clinical outcomes and the repair is better or more optimal with the middle fossa than the transmastoid.
I would say that's part of our strength, is that we have two individuals teaming up to do this procedure. And so going from above is not something that is routine for most head and neck surgeons. For someone like yourself, a neurosurgeon, obviously you have a lot more comfort. And so bringing that expertise to the duo is quite beneficial. And I do believe it allows us to get good exposure with a more minimalistic and minimally invasive technique.
So the way we repair superior semicircular canal dehiscence in a routine case, and the overwhelming majority of these are amenable and optimal to be approached through a middle fossa craniotomy. Tell us about the way we repair a superior canal dehiscence here at UCLA, Dr. Gopen.
So we do call it a minimally invasive keyhole craniotomy. And so my colleague, Dr. Yang, does the initial approach. So it's a small cut above and in front of the ear. We'll have some pictures that we'll show in a little bit. Going through the skin, the musculature, and down to the bone, a small opening in the bone about the size of a dime is made. And through that opening, Dr. Yang slides underneath the lining of the brain to get to where the dehiscence is. And at that point, I do the repair.
And the repair here, it says it's repair with bone wax, temporalis muscle, fibrin glue, and a small piece of titanium mesh, otherwise known as the IQ dome.
Yeah, so that's something that we kind of evolved into. So as we did the surgery for the first probably 5 years, we were using bone wax with some fibrin glue and a bone chip to kind of take pressure off the area. But we found that the bone chip wasn't very robust and it resorbed, and some small fraction were having delayed failures after initially being good. And we adopted the use of this titanium mesh. It's a very thin, pliable mesh that we put in the bone wax, and it does a much more robust job of protecting the area, and we describe it as rebar in concrete, where it's giving you an infrastructure around which the repair material of the bone wax sits, and we have been very happy and had a much reduced risk of having recurrent symptoms after using that material.
And the very first patient who we used that titanium mesh in, he colloquially called it the IQ dome because I'm Isaac and he's Quinton. And so we've kind of just played with that and stuck with the IQ dome.
That is truthful, yes.
Yeah, and so this is what we've been doing is the MIS approach. And let me see if I have that picture. So this is that approach that Dr. Gopen was talking about. And yeah, we pioneered. I think the right word is pioneered. Dr. Gopen is giving me far too much credit. This is a team, multidisciplinary team. You need the ENT surgeon who's skilled. You need the neurosurgeon, the neurocritical care doctor, the neuroradiologist. Actually, you also need a neurophysiologist who's in the OR. They don't get any publicity or any play that they're part of the team, but they're so critical. The neuronavigation. Every member of our team is doing this, but we did pioneer this. In 2014, we came up with a way to approach middle fossa craniotomy for SSCD through an incision that's just a little bigger than an inch. And then we make an opening that's smaller than an American dime, 10 cents. We make it smaller than, and using that keyhole approach, we've been able to approach the SSCD and repair it and have just as good, if not better results, because the smaller MIS approach, we believe, leads to shorter recoveries, shorter operative times, and less morbidity with better outcomes. And so we do this in about 70 minutes because it's shorter operative times. And so this is the volume of our case, as you can see, that we started doing this in 2010 and 2011. And here now in 2021, we're quickly approaching doing our 500th SSCD. Now, we mentioned other surgeries. Dr. Gopen has done thousands of mastoidectomies, and Dr. Gopen was inferring, and it's true, that I've done thousands of craniotomies. But we're not talking about other kinds of surgeries. We're just talking about SSCD. And we have almost done 500 SSCD specific repairs. What do you think about that, Dr. Gopen?
I do find that the experience matters a lot in surgery, and the bigger the volume, the more the outcome is going to be beneficial to the patients. And so I do think that's an important thing to consider when you're, thinking about who's going to do your surgery is their surgical volume. We certainly have a robust practice together, and I think it's something that we both focus on and embrace, and we've been fortunate enough to have a lot of patients come our way.
And so yes, we've done almost 500 of these with the shorter, minimally invasive keyhole approach. We believe it leads to less pain, shorter operative times, and quicker recoveries. And this is the way we do it. You can see the hole here. This picture here is even a few years old. It's actually smaller than that now, but less smaller than an American dime. The other thing about this is that it leads to less hair shaving, a smaller scar, and so shorter OR time, less pain, quicker recoveries. You can see a traditional approach here. This is a larger, much bigger scar above the ear, and then you have to shave a whole bunch of hair. Here you can see that this incision is going to be much more smaller, leading to much smaller hair shaves, leading to less morbidity, we think, in the overall approach. What do you think about the challenges of the middle fossa craniotomy, and why do you think that this is a unique and special way to repair SSCD?
So I think it's a great question. The difficulties when you're really shrinking things down and doing these minimal invasive things is making sure your opening is in just the right spot. So we really rely heavily on our navigation system, and so that is basically for the discussion, the GPS of surgery that we use. It's a little pointer that intraoperatively put on where we're going to make our incision that tells us right where things are based on the imaging. And so we use that to center our small opening right where we want it, and then we can confirm intraoperatively that we're in the right location with that image guidance system. And so that is something that we rely on heavily. We have adopted that. It's something that is common in the neurosurgical realm. I don't use it in head and neck surgery very often, but it is certainly quite useful for these cases.
Yeah, because as you note here, it's a flat arcuate eminence. You can have a flat temporal fossa, and if your middle fossa is flat without any anatomic guidance, that's a real challenge to find the superior canal dehiscence. And in a lot of our patients, they have very thin tegments or very thin middle fossas. They have multiple holes into their mastoid. And so when that's the problem, how do we fix that? And so here's an image of the neuronavigation system we have here at UCLA. And we use this brain lab navigation to identified, like Dr. Gopen said, it's like GPS navigation, just like it navigates you when to drive. And we've done this almost 500 times. We've done this surgery almost 500 times. There's a neuronavigation team in every single one of our cases that helps us. And the question I get back is, well, if you've driven to your house and to the hospital 500 times, do you still use GPS navigation to drive home and to the hospital? What do you think about that? Do you still need to use navigation?
Well, certainly each person is unique and individual, so their anatomy is going to be different. And as you have alluded to before, the tegmen is the term for the surrounding bone around the area of the lesion, the dehiscence. And that bone inevitably has a bunch of little holes in it. So it's very easy to see a little hole and be thinking maybe that's the dehiscent or maybe it isn't. So each person is unique and individual. And so you can't just assume it's the same drive home every time because it's a different drive every time. That's not an acceptable analogy.
Oh, it's not an acceptable analogy. Because when we're just driving home, if you're just driving to the hospital or home and if you're a few minutes late, that's no big deal. We're doing this in surgery. People's lives, people's outcomes, and me and Dr. Gopen, if you know anything about us, we're insanely dedicated to getting the best clinical outcomes for our patients possible. And so neuronavigation, GPS navigation, it has to be done. And really, neuronavigation is a misnomer. It's actually computer-guided assisted surgery. Now, I don't think the computer can do the surgery by itself, but it's very helpful to have a computer. His brain, I love brains, your brain, my brain, working on this with the assistance of a computer brain to guide us and help us because the outcomes and the stakes are really high. And so you want the best that you can do with computer-assisted guided surgery. And I think this helps because we use this on every single one. The other thing about computer-assisted and guidance is when I use Waze on the way home, the Waze and the computer will know when there's traffic, when to divert me, when to run around. So even though I've done this drive almost 500 times or this surgery, you're right, the analogy is not appropriate. We use computer-assisted navigation because that really makes our surgery the best that it can become. And so this neuronavigation, I think, is incredibly precise. And then the other thing is that we've done almost 500 cases with navigation now. And so our neuronavigation team, and our GPS navigation, it keeps getting better and better and better. What do you think about the way our navigation has improved over the years?
I would say in addition to navigation, we do use the anatomical landmarks. So we're relying on those, and that's all stuff that as you do the case over and over again, we're getting more perfect. But navigation has gotten better. Their systems, their computers have gotten better, and the team that supports us is also more comfortable doing these cases because they've done it so many times. They know what we're looking for. They know how to optimize things.
Wait, are you saying that there are lines that you can look for in the surgery, anatomic lines?
There have been some lines mentioned by one of us as part of the surgery. But yes, we do use anatomical guidance by the patient's own anatomy as we can make measurements. Almost all of these lesions are about 2.5 centimeters, which is 1 inch deep from the bone. And so we actually measure on the scan and put it on a little instrument, and then intraoperatively you can make a measurement that is independent of the navigation system, but helps to confirm that we're in the right location.
And so Dr. Gopen was mentioning lines, and Dr. Gopen and I have identified the external auditory canal, and a line up from that we've colloquially called the line of Gopen. And then the root of the zygoma, a line parallel to that, is called the line of Yang, and that you're trying to get to that intersection. And that's now published in the scientific literature, and Dr. Gopen and I have published over 30 papers now looking at all of our data of almost 500 patients in our series looking at SSCD. What do you think about the body of knowledge and literature that we've published now?
Yeah, I'd say it's robust. We're doing our best to support not only our practice, but the world literature and make sure that we're disseminating information that we think is important about these cases. Obviously, we feel good when people are getting adequate, good care wherever that is. And we've tried our best to try and do that in a systematic way that's not biased and try and present our data.
Yeah, because we aren't trying to keep this. We think this is the right way for all SSCD to be repaired. So we're essentially publishing books to help train fellows, help train other doctors, medical students, and residents so that they can learn about how to approach this in a keyhole middle fossa craniotomy. And so we described our results. This is from the Journal of Neurosurgery here by Dr. Gopen, Dr. Chung, and myself. This is another paper that we published looking at how to use AI, artificial intelligence, and computers and deep learning on how to precisely find the superior canal dehiscence. We published this in the Red Journal of Neurosurgery. This is a paper that we looked at the metabolic markers. So UCLA is a huge research institution. We're an academic place, and so we're always trying to find and study the things that cause SSCD. What do you think about metabolic markers in SSCD, Dr. Gopen?
So there are certainly overrepresented cases of things like thyroid dysfunction that we've identified and published, and it's not entirely known what the causality is, but obviously any condition that's going to affect your bone metabolism, so things like parathyroid, hyperplasia, adenomas, things that give an elevated parathyroid hormone are going to be things that we're going to be screening for. Calcium levels, we have produced some evidence of abnormalities that we have found in some of our patients, but it is very individualized, and I would continue to say the majority of patients don't have an actual cause that we can identify for the condition.
And then we've also studied some of the issues that happen with surgery. We were always concerned about hearing loss. What do you think the rate or the chance of losing hearing is during surgery with a metatarsal craniotomy?
So with any surgery, you're obviously going to be concerned with the risks of the procedure. You need to be a well-informed patient and know what the risks are. Statistically speaking, it is one of our higher risks, which would be hearing loss. We do monitor the hearing for all patients that are having the surgery, and we do see some drop in hearing during the procedure in a small percentage. I would say it's around 5% of those patients, maybe between 5 and 10. In many of those, it's temporary, and by the end of the surgery or shortly thereafter, it is recovered. But there are some that go on to have long-term hearing loss from the procedure. I would say that risk is probably down around 2%, something in that realm.
So about 2% in the long-term realm. And Dr. Gopen is inferring, and it's true, that for every one of our SSCD cases, we have a team, not just me and Dr. Gopen. There's a neurophysiologist in the OR who's checking on your hearing throughout the entire case.
That's right. In addition to hearing, they're checking other things to make sure you're safe. And so those would be the other functions of neural monitoring that they're doing for us all the time. So it's a pretty sophisticated system.
Yeah, they're doing other things such as EEG, making sure your sensory inputs are okay, that basically your toes and your fingers and everything are still connected and hearing up. But they're also checking your hearing, which I think is just so cool. And so the last few things are about the future of where our research is continuing to go. What do you think about the research involving and studying unilateral SSCD and outcomes with bilateral SSCD?
So many of our patients have the condition in both ears. In fact, it's more than half. I would say it's roughly about 2/3 in some of our series that we've published. And so it's a problem. It's a problem because patients want to get better. And obviously, in some cases, you can fix one side and that's enough. But oftentimes you have to move on and deal with both sides. And we're trying to get information as to how safe that is to do, how likely they are to have improvements in outcomes, and that's a lot of what our research efforts have been geared upon.
What do you think about the way you repair the SSCD? Do you think that there's a difference whether you plug it, whether you resurface it, or you seal it? I mean, this is really, you're probably the world expert in this, if not the United States or the whole world. What do you think about the different ways to actually, once you get there, repair the SSCD?
So there are other experts. There are other world experts. I want to.
But you're one of them. I didn't say you were the expert. I'm saying you're one of the experts.
But having said that, there is a notion about what we call plugging versus resurfacing. And so plugging is when the canal is actually blocked. You're taking material and blocking that fluid-filled sloshing effect of the canal. And that has been proven to be better than what we call resurfacing, which is passively laying something on top of the canal. And that was an older version of the surgery where you just took some flimsy fascia or other material and just kind of laid it like a little carpet on top. What I am trying to do is what I call sealing. And so I am trying to take bone wax and get it to plug up the top defect, but not block the actual fluid-filled part of the canal. And that allows you to preserve the natural function of the organ, but also get the best of both worlds where the actual defect is sealed off. And we have shown with our own studies that that actually does lead to better outcomes than the traditional plugging procedure.
Because that's the best of both worlds.
Correct.
You're sealing and fixing the dehiscence, but you're not destroying the function of the superior canal.
And not everyone is eligible for that, because if the dehiscence is big enough, no matter what you do, the repair is going to fall in and block the canal and plug it. So it tends to be patients that have a slightly smaller dehiscence, maybe average to smaller than average, that you can get away with doing the sealing and getting a reliable repair. But if it's a big enough opening, it's probably going to get plugged.
What do you think about the timing? I get that question a lot. Dr. Yang, can you just go in both sides and fix the semicircular canal dehiscence on both sides?
Sure. As you well know, we do not offer simultaneous both ear surgery at the same time, right? So
You could do one side, I could do the other, and we could just kind of
meet in the middle? No. I don't think that that is something that's safe. We have not done that, and we will continue to not do that. I would say the fastest we have operated is roughly around 6 weeks between the two sides. And that's something that seems to be safe enough to do. Our preference is to wait a little longer. So giving the body more time to adjust to the new balance system from the repaired side. If you can get a few months under your belt, that seems to allow people to do better when they move on to the second surgery.
Even with the multidisciplinary team and the neuronavigation and the IQ dome and the smaller surgery doing the less pain, quicker surgery, quicker recovery, I still want the body to be as strong as it can be before you go back in for surgery. And so I'd recommend a few months in between doing both sides.
I agree.
And yeah, you're right, we'll never do both sides at the same time. The last thing is, what do you think about the size of the dehiscence and symptoms? And do you think size is more important or location? Do bigger dehiscences cause more symptoms? Or do you even need a hole to have symptoms?
So it is truthful that thin bone, if it's thin enough, can cause symptomatology. So that's been well delineated in the literature. So you don't actually have to have a technical opening. We used to be worried about that sort of stuff. But thin bone can cause symptoms. I do feel that there's enough evidence in the literature to show that if you have a larger dehiscence, you're going to have more symptoms. You're going to have a higher chance of having a bigger air bone gap on your hearing test, and you're more likely to be having vestibular and dizziness issues, including the post-operative, and that's one thing that we have uncovered is, if you have a bigger dehiscence, you're more likely to struggle with your balance and dizziness recovery for a longer period of time after the surgery.
Because they're going to come with a bigger air bone gap on their hearing test. And so they're going to be symptomatic when they come and see you with the big hole. Do you think the location of it matters, whether it's anterior, superior, or posterior?
Not as much as certainly the size of the dehiscence. The ones that are more towards the entrance where you're going in to fix it are a little easier to get to. And then if you think about it like a hill, when you're right at the top, it's still pretty easy to access. And then the far side's a little more difficult to get to. But I don't believe our own internal studies have shown that the patients with deeper dehiscences have any worse outcomes than the closer dehiscences, at least in our series.
Yeah, we're evaluating, trying to figure out and come up with a grading scale for where it occurs on the actual arcuimmanence. And the last topic is thinness, as you were referring to. Do you need an actual hole to have the hole? Can you have SSCD syndrome without an actual dehiscence? And what is surgery in these patients like?
Yeah, so thin bone is certainly something that can cause symptoms, and those patients do very well with the surgery. We were early on reluctant to offer surgery without seeing an actual opening, but as we got more information and the literature supported doing surgery for thin bone, we found that those patients are among our best performers because it protects their ear from getting very aggravated with the surgery. And so as they go through their healing process, they have less inflammation and aggravation, and so they actually do really well as a general group with their recovery.
Yeah, when I think about the thin bone, I kind of think of a really big apartment complex, and you're in an apartment complex and your neighbor's really noisy. And if SSCD is just sound escaping, if your walls are thin enough, you don't need an actual hole to have the sound of your neighbor bother you. And so I think you can actually have the disease without an actual hole.
I don't think I've ever quite thought of that analogy, but I think it's an excellent one.
You probably didn't live in many apartments like me.
Probably not.
And then the last thing is looking at CT evaluation of normal bone thickness. What do you think is too thin? Because that's the next question. It's easy to walk away and say, well, Dr. Yang and Dr. Gopen say, it's thin bone. He gave the apartment analogy, my neighbor's too thin. But in medicine, and if you're going to be at UCLA and study this and publish over 30 papers, what is too thin? If thin is the problem and it's no longer a hole, what is thin and what is too thin?
Right, so that's exactly the point, is you don't want to get into a situation where you're saying, well, geez, you don't even need to have an actual hole to qualify for the surgery, and now you're doing surgery too much. We're very conservative. I would say we have a very high bar when it comes to accepting someone for surgery, and we want to make sure that they're going to do well to the best of our abilities. And so We're trying to gain information about how to make some of these determinations. And as such, we looked at normal scans and said, hey, what's the normal spectrum of bone? And we found that if your bone is less than 0.4 millimeters thick, that's under the 10th percentile, meaning that 90% of people have bone that's thicker than that. And we use that information. But again, in isolation, the scan is not the diagnosis. You have to have other symptoms and objective testing to qualify.
I mean, thinner than 0.4 millimeters, that's like thinner than just 3 or 4 hair strands. That's super thin.
Yeah, it's pretty thin.
So in conclusion, to wrap these things up, the overwhelming majority of our patients have resolution in at least one symptom. You have autophony, oral fullness, imbalance, dizziness, pulsatile tinnitus, and brain fog and cognition. We didn't even have time to talk about that. And those patients have really good outcomes. One of the areas that is an area for future research is patients who develop headaches or ringing tinnitus. What do you think about patients that develop that after treatment or developing headaches?
Yeah, I think the slide's a little misleading because obviously most of our patients have an improvement in most of those symptoms. And so it's not like you just have to pick one symptom off that list and that's all you get. No, most of our patients are having the vast majority of those symptoms get better. To answer your question, headaches, they are common, obviously for many reasons, but we do see most of our patients have a headache that is probably from the actual pathogenesis of what's going on and causing that bone to disintegrate. And as such, when you are able to repair that area, it does seem to improve their headaches. I think our rates, and you can correct me if I am mistaken, but it's around 70-80% of our patients have a pretty dramatic reduction in their headaches from the condition when we do the surgery.
Success is a team sport. We've mentioned this several times, that Dr. Gopen and I are not here alone. We are supported, including our colleague, Dr. Johnson, but our departments, the Department of ENT and Neurosurgery. It takes a whole team to do the research. We've had several fellows now to have a whole team of both undergrads, medical students, residents, other faculty members. It takes a whole team. What do you think about the multidisciplinary team that we have here?
Yeah, I think UCLA is a great place to be. I think we do have the multi-centric concept down pretty good. I do feel we have a lot of other support from other services, some of which you've mentioned. And I just want to thank you, Dr. Yang, for all your support over the years, and Dr. Johnson for this opportunity to talk to everyone about our love and joy of treating semicircular canal dehiscence.
Yeah, and I want to thank Dr. Gopen. I mean, he's my partner in doing this. He's my best friend here at UCLA. I love doing this. I love dedicating our lives to making our patients' lives better, dedicating everything we do to get the best outcome we can. And when I look at that volume that we're almost at 500, it's not just our surgical volume that has gone up, but our neuroradiologists, they're now specialized because they've seen it hundreds, if not thousands of times. We have specific neuroanesthesia. We didn't even mention them. But Dr. Moreland, who's the chair of neuroanesthesia here at UCLA, we've worked with her so many times. Dr. Buckley, Dr. Vanderwill. I mean, we have a team of anesthesiologists that just do anesthesia for neurosurgery and for skull base and complex cases. We have a neuromonitoring team. We've mentioned that. There's so many of them I can't mention, but we have them in on every one of our cases. The neurocritical care team with Dr. Vespa and Dr. Blanco. Even after the surgery, you will have a neurology team, a neuro ICU critical care team that's in the hospital 24/7, and their only job is to take care of critical care patients. We have a whole team, and then we have a neuronavigation team in every single one of our cases. It really just takes a whole city to make each one of these work. And so I do really want to thank the whole team. Thank Dr. Gopen, Dr. Johnson, everyone as part of the UCLA team that makes this work, because one of us just could not do it alone. And lastly is our sources of funding. We've been so fortunate to have funds that come in that support the SSCD program here. We have the Girton Skull-Based SSCD Research Fund that has funded several fellows now, and the Tina and Fred Siegel Skull-Based Research Fund that allows us to do this amazing work. And if you have any questions or any issues, don't hesitate to reach out to us. I put Dr. Gopen's email. You can always email him first. You can also email me too. This is my email address. This is our phone number. You can reach us. Dr. Gopen is not big on social media, so you can't really find him except by hashtag. He lets me do that work, which is harder, and that's why we're friends. But you can find me on social media. You can DM me on Facebook, Instagram, Twitter. We're always available. And if you have any information or phone numbers, you can always contact us. And Dr. Johnson, thank you so much for letting me,
Oh,
Dr. Gopen.
thank you, Dr. Yang, Dr. Gopen. I mean, this is a tour de force talk, and congratulations on like a tremendous body of work here. And like we mentioned, this is not a procedure that's done everywhere, and it really behooves, helps the patients and behooves you guys that you've built such a program around this disease process. And so congratulations. I just have a few questions. You have amazing expertise, but from the practical standpoint, from a patient's perspective, how long would they expect to be in the hospital and recovering from a procedure like this?
So a lot of the recovery depends on how dizzy and how much balance problems they're having. So a patient that's having minimal to no dizziness, they leave the next day pretty reliably. The pain isn't too uncontrollable. If they're really dizzy, then we often will give them some steroids to help with that, and they may stay an extra day. Takes a few weeks for that to unload, and I would say for work purposes, we often recommend 4 to 6 weeks off work just to make sure you're not dealing with this when you're going back to work.
Perfect. As far as recovery of the symptoms or improvement in the symptoms, is that something that happens right away, or it takes weeks to months to get better?
One of the amazing things about superior semicircular canal dehiscence is that there are times when the sound, the autophony, the heartbeat sounds, that they go away dramatically. And that's a remarkable experience as a surgeon. Right after surgery. We go and see them in post-op, and they're saying, I can't hear my heartbeat anymore. I don't hear my eyeballs moving anymore. Or some of the people who came in with those sound-canceling earbuds we were talking about, Apple, Samsung. I'm ready to endorse you if you want to come talk to me. But the sound-canceling headphones and the sounds bother them. There are bells and alarms going off in the ICU, and they look at us and go, Dr. Yang, Dr. Gopen, the alarms in the ICU, they aren't bothering me anymore. And so sometimes that does happen right after surgery. Other times, especially I think with balance, because balance is something that you may have had for a while. It's hard to test that immediately after surgery. Sometimes that takes a few weeks to get better after surgery. In a small subset of our patients, they have balance that's different after surgery. It's a little more challenging. And that makes sense because, as we talked about earlier, the superior semicircular canal is not a hearing organ, it's a balance organ. And so when you fix that, then the balance is different after surgery. And then sometimes that takes a few weeks to a few months to get better.
Got it. Someone's out there, they're watching this presentation, then they tell themselves or someone they know or love has these symptoms that you brought up. And so, maybe I have this disorder or my loved one has this disorder. What is the sort of next best steps that they take to kind of find out if they have it or not radiographically to go along with the symptoms? Who do they see? What's their next steps to kind of move along the process to diagnosing this?
So the majority of patients that we deal with are from out of state. Yeah. We've had patients from all over the world come see us, right, Dr. Yang? We've seen people from Singapore and South Africa and
Dubai, Japan, all over the world.
Yeah, and I would say our initial support is to do a video visit. And so we offer a video visit for anyone that wants us to review their films, and we can look over the basics and kind of let them know if we kind of agree with the diagnosis and what the path is. And then when they're ready, if they are for surgery, they can come in and we do everything in a pretty tight turnaround and get them back home without too much trouble. So it is safe to fly after surgery, and so a lot of patients come into town just for a few days and then go back home.
Yeah, I think the easiest and most common thing to do locally is, number one, to get a hearing test to look for that air bone gap. And then the second thing is to get a temporal bone CT. And Dr. Gopen and I have seen temporal bone CTs from all over the world now. And we see the quality of that. And that's also why we won't do surgery here at UCLA without another CT scan and an MRI done at here at UCLA. That's what allows us to do that computer-guided surgery, is that CT and MRI that we get here. And it also allows me to see that the CT scan that we get here is of exceptional quality, very high resolution. And then you have some of the most experienced neuroradiologists looking for SSCD, looking for that canal dehiscence. And so I think those are the steps, is a hearing test and a temporal bone CT. And then yes, Dr. Gopen mentioned that we do a lot of Zoom and a lot of telemedicine visit these days.
And even before that, like someone doesn't have any imaging, what is the next steps? Do they see a particular type of doctor to get the workup done? Who has expertise in this? Who should they seek out?
Yeah, typically an otolaryngologist and ear, nose, and throat doctor. One subset of that is called a neurootologist, and they do have the expertise to deal with this problem.
Perfect. And then they can order the appropriate hearing test and diagnostic imaging. All right, yes. Great. what are the success rates of people getting substantially better from the surgery? Like, do you guys have a percentage of people that have improved in all the different metrics? Like, just as an overview of how successful people can expect their symptoms to improve.
And that's really important that we've done almost 500 of them, and we track them all with almost an insane kind of type A personality to track the results and see what they have. If you have just sound-based autophony, pulsed out tinnitus, those symptoms have the highest chance of improvement. This surgery, this minimally invasive keyhole surgery, is best at that. And those odds of success are 80 to 90%, if not higher, that those sounds will go away or be significantly diminished. For balance, I think it's a little bit more challenging, but the odds are still 70 to 80% that I think balance will improve with SSCD surgery. What do you think, Dr. Gopen?
Yeah, I would agree. Those are our own internal statistics. I think the hardest thing for us to reliably predict is the hearing improvement. And for as much as that does happen in some patients, that's our weakest statistic. That's in about half of patients, actually, their hearing gets better, and the other half, it probably stays about the same.
I think the areas that's most challenging, one is redo surgeries. So if you've had surgery somewhere else and then you come here, we try our best to make that better, but I think the odds are stacked against us from the get-go in that scenario. And then number two is bilateral. I think if you have it on both sides, if you have it on just one side, your chances for success are really, really high. But if you have it on both sides, I think your odds are just a little bit less because now you're dealing with repaired balance, repaired hearing in both sides versus having it just on one side.
Makes sense, makes sense. And as far as the cosmesis of this, is this something that people can see, once you've recovered from surgery, you can see the scarring? Do you have to shave your head? How much is this to go through from a cosmetic perspective?
So we're always going back and forth. Dr. Yang, of course, being a neurosurgeon, likes to shave a little bit more than my minimalistic approach, but it's either way, it's a pretty small. You're talking about a couple finger breadths above the ear. The scar heals very nicely, and I would say for the most part, it's not anything that you're aware of after you recover.
Yeah, great. All right, that's it for my questions. Any other comments or things you want folks to know about this?
No, I'm happy to have this opportunity, and I again want to thank you both for your time and efforts today, and hopefully we can continue to do this for many years to come.
All right, great work. Thank you all for joining us for this webinar, and hope to see you in the next episode. Thank you.